Uh, Good morning, everyone. My name is Dr. Mrinaal Valmiki. I graduated from Sardar Patel Medical College in India. Today, I'm going to present on subacute sclerosing panencephalitis. But before I begin the presentation, I would like to thank Dr. Stein, Dr. Panad, and Dr. Naka for giving me this opportunity and my fellow rotaries for their time and attention. In this presentation, I'm going to talk about the case introduction of subacute sclerosing panencephalitis, epidemiology, pathophysiology, clinical manifestation, diagnosis, treatment, prevention, prognosis, and shifting paradigms of measles vaccination. So I never seen a case of subacute sclerosing panencephalitis, and because of that, I'm going to present a case report. A 14-year-old girl previously having jerks in cognitive decline for 15 months presented with insidious onset of bilateral vision loss. In the past 2 months, she lost her vision completely and she developed weakness in her right upper and lower limb and needed support to walk. She developed difficulty swallowing for both liquids and solids. The patient was bed-bound, completely mute, with bowel and bladder dysfunction from last a month at the time of presentation. Initially, 15 months ago, she developed jerks in cognitive decline. She has a history of right-sided intermittent deviation of angle of mouth with tonic closure of eyes. She had right-sided hemifacial dystonia for 1 month. She does not have any history of any other major medical illnesses, no family history of similar illness, and she never received any vaccinations. So during her initial visit, the doctors initially investigated for subacute sclerosing panencephalitis with progressive myoclonic epilepsy as differential diagnosis. They investigated they ordered CSF studies, MRI of brain and EEG. During her initial investigations, CSF and MRI were normal, and thus they ruled out subacute sclerosing panencephalitis. They treated her symptomatically for her jerks with valproic acid and clonazepam, which transiently improved her condition, but then it deteriorated. During her latest visit, vitals were normal and general examination was unremarkable. The patient was awake but mute, inattentive, and spontaneously moving her eyes. Pupils were normal and light reflex was normal bilaterally. Gag reflex was hypotonic and led by rigidity in upper and lower limb, with neck rigidity was observed. Tone was normal on the left side, intermittent dystonic posture in right-sided limbs observed. Deep tendon reflexes were brisk and plantar reflex was flexor. So they again ordered some investigations, and this time the blood work showed no abnormalities. LFT, RFT, and thyroid function test, plasma lactate, vitamin B12, homocysteine, all were within normal limits. They didn't see any Kaiser-Fleischer ring on slit lamp examination. CSF was acellular, but there is an increased titer of anti-measles antibodies. On MRI, there was T2 hyperintensity involving cortical and subcortical white matter of parieto-occipital region. EEG shows intermittent generalized slowing of periodic sharp and slow waves discharge. For treatment, the patient fulfilled the criteria of subacute sclerosing panencephalitis and was treated with intrathecal interferon and valproic acid. She has extrapyramidal symptoms, and for which she was treated with trihexyphenidyl and pramipexole. The outcome: the patient is bedbound, completely mute, and in a vegetative state. She has progressive, persistent right limb rigidity and right hemifacial dystonia. This was the case report, and I will talk about what is subacute sclerosing panencephalitis is. So it's also known as Towson's disease or encephalitis. It is a progressive neurological condition which is characterized by inflammation of brain. It's a chronic complication of measles with delayed onset and outcome, which is always fatal most of the time. It appears to result from a slow but persistent infection with an altered measles virus that remains dormant intracellularly in central nervous system for several years. Researchers believe that viral apparently regained virulence after 2 to 10 years and attacked the cells in the CNS. This slow virus causes inflammation and cell death, leading to inexorable neurodegenerative processes. So let's talk about the epidemiology. And for talking about epidemiology of SSPE, we need to talk about the epidemiology of measles. So the latent period between measles infection and symptoms of SSPE can range from 3 months to 18 years. Thus, the development of symptoms can take several years after the infection. The incidence of SSPE is higher in males as compared to female. Approximately 1 to 11 cases per 100,000 cases of measles, and the risk is higher if the infection is acquired earlier in life, that is 18 cases per 100,000 cases of measles. But with widespread use of vaccines, the incidence of SSPE has been reduced dramatically, with less than 10 cases reported per year in the United States. Here is the graph showing the years with measles infection and the presentation of subacute sclerosing panencephalitis, and it shows how many years it takes to present for the symptoms development of SSPE. Now let's talk about the pathophysiology of SSPE. It's still a mystery, and there are several factors that can be involved in the pathophysiology of this disease, including defective measles virus, which interact with defective immune system. The virus causing SSPE has defective matrix M protein, which is here. It is responsible for assembly, orientation, and alignment of the virus during its replication. This defective virus remains in the neuronal cells for long period, and it can infect the oligodendrocyte, which is responsible for demyelination seen in SSPE. So here's the life cycle of the virus. It is an RNA virus, and so when it infects a cell, using reverse transcriptase, it transforms its genetic material into DNA, integrate its genetic material into the host cell, and then with the help of matrix M protein, it aligns itself and then bud out of the cell. But with defective matrix M protein, it cannot do so, and it remains in the cell. And another possibility is defective immune system. So for clearance of virus, our immune system secretes interleukin-12, CD4 helper T cells, and interferon gamma. But viruses have several mechanisms by which they can decrease the response of our immune system. Like they can decrease the presentation of MHC class 2 on the cells, so antigen presentation cannot occur, and the CD4 helper T cell cannot apoptize the infected cells, or they can decrease the secretion of these inflammatory mediators, which leads to increased production of the virus. So now let's talk about the clinical manifestations of this disease. It occurs in 4 stages, with stage 1 has mildest symptoms, and following throughout the stages, the symptoms increase in severity. So the signs and symptoms in the stage 1 are often missed due to their mildness, subtle behavioral change, uh, decreased school performance, irritability, reduced attention spans, and span and temper outbursts, fever can be seen, and fever, headache, and other signs of encephalitis are often absent. Now, stage 2. The hallmark of this stage is myoclonus. It begins in the single group of muscles spasm and jerks involving both axial and appendicular muscles. Myoclonus coincides with extensive inflammation of deeper structures of brain, such as basal ganglia. It presents as involuntary movements, repetitive myoclonic jerks, but the consciousness maintained in this stage. Now, third stage, involuntary movements disappeared and are replaced by choreoathetosis, immobility dystonia led by rigidity due to destruction of deeper centers in basal ganglia, sensorium deteriorates, and dementia, stupor, and coma develops. And the final stage is stage 4. In this stage, loss of critical centers that supports breathing, heart rate, and blood pressure, they are destructed, and death can occur after this stage. The progression of the stage follow a course such as acute, subacute, and chronic. And with acute progression, death can occur within months, and with chronic progression, it can take several years. Now, let's talk about the diagnosis. The clinical course of the disease is required to establish the diagnosis and at least one of the following investigations. The CSF findings. In the CSF findings, anti-measles antibody, which increases. The EEG shows characteristic pattern with periodic discharge occurring at regular intervals, and this can be normal in stage 1 of the disease. And then MRI and CT scan findings. T2 weighted MRI shows periventricular and subcortical white matter involvement, neuronal degeneration, starts in cortical subcortical white matter with progression with progress with periventricular white matter involvement in diffuse cortical atrophy. Here we can see T1 MRI and T2 MRI. These scans were taken initially when the patient presented for the first time, and these are follow-up scans. We can see how ventricles are enlarged and cerebral atrophy, and the cerebrum is cerebral atrophy. And biopsy, we do not do it routinely. We only do it either during postmortem or So we can see here typical lymphocytes in the brain, the intranuclear inclusion bodies of measles, astrocyte proliferation, and viral nucleocapsids. So now let's talk about the treatment. There is no specific treatment for SSPE, so the management of this condition is mainly supportive and symptomatic. Maintaining hydration, oxygenation, making patient comfortable are the goals of therapy, such as antipyretics for fever, airway humidification, and supplemental oxygen for patients with respiratory tract involvement. For myoclonic jerks, carbamazepine has shown significant improvement in the jerks. There are several theories and trials that are researchers are doing several studies to identify any treatment that can either slow down the progression or prevent the disease. Several isolated reports about effectiveness of isoprinosine with or without interferon suggest significant improvement, but it was not confirmed by controlled clinical trials. Some studies showed intrathecal interferon alpha with or without inoxiplex demonstrated improvement in symptoms in approximately 50% of patients. An unusual case report demonstrated dramatic improvement in neurological and general condition, as well as arrest and progression of demyelination in CSF after beginning a high ratio ketogenic diet. But I believe it is because the researchers believe that it is because of the anti-inflammatory and antioxidant effect of ketogenic diet, but I believe the patient has been in remission spontaneously. Prognosis. The prognosis of SSPE is not good. It's patients always dies within 1 to 3 years of diagnosis. Small number of patients have disease progression even rapidly and dies within months. A very small number of patients have chronic progression with some relapse and remission in the symptoms. And only 5% of patients may experience spontaneous long-term improvement and regain of lost function. Now let's talk about the prevention. Preventing measles is the only effective and real cure for SSPE, and vaccination is the only effective means to prevent measles. Prevention is always better than cure. And shifting paradigms. So measles vaccine was introduced in 1960s, and since then the cases of measles has decreased dramatically. The prevalence of SSPE depends on the prevalence of measles, with 634 cases from 1956 to 1982, and which was decreased from 2 to 5 cases after 1982 and in 1990s. But as per the current reports, less than 10% cases were reported in the states. However, the vaccine hesitancy is increasing among the population, and this might result in the surge in SSPE cases. So vaccines are very important to prevent this deadly disease. And here are my references. And thank you so much for your time. And feel free to ask any questions. Thank you.